Hi, friends. I'm one of the experts on PCOS. So if you're coming here to learn about your PCOS, I'm the person for you. You're also going to want to subscribe to the channel and follow along because this video has lots of great information on your body, your fertility, your hormones, and your overall health. If you want to get pregnant one day in the future or optimize your lifestyle to better understand your health and hormones, this is the channel for you. You can also play a role in the community tab and help direct what videos we should do in the future. Now, PCOS is very common. 1 out of every 8 to 10 women will have PCOS. But PCOS is often misunderstood and very frequently dismissed by OBGYNs or general practitioners. It's not that they want to dismiss it, but I think the problem is that sometimes when we have the symptoms, we're so far removed from trying to get pregnant that someone just hears the main complaint, an irregular period or acne, and recommends treatment or management for that without a full investigation into what PCOS is. Helping you understand your disease, do you really have it, and what do you need to know now and in the future is key. And that's the thing I see all the time from patients. They'll say, do I even have this? I don't even know. I had to research it on my own. And it is so frustrating. So let's start with number 1. What is PCOS? PCOS stands for Polycystic Ovarian Syndrome. Essentially, it's a condition where the brain and the ovaries stop communicating appropriately. We see abnormal pulses from the brain, which cause an abnormal response in the ovary. People with PCOS also have a really high egg count inside their ovaries, which leads to some of the hallmarks of the disease. The way I like to think about this is, imagine the ovary has a little vault inside where all your eggs are kept. When you're born, that vault is full. Throughout your life, eggs come out of the vault. And when the vault is empty, you're in menopause. What we know is that the number of eggs that come out of the vault each month relates to how many are left inside. So let's think about PCOS. Suddenly the vault is very crowded, and it sends out more eggs per month. When that happens, your brain interprets signals differently. Each egg makes a little bit of estrogen, and that changes how the brain sends out hormones to get eggs to grow. Also, it becomes harder for an egg to respond to the normal FSH signal from the brain. FSH, follicle-stimulating hormone, is a well-known hormone that stimulates one follicle, or egg, to grow. But if you have a lot of eggs outside the vault, think about the FSH signal getting diluted among all of them. This makes it harder for regular and predictable ovulation to occur.
Common features of PCOS. With PCOS, we typically see polycystic ovaries on ultrasound. This appears as lots of small follicles centered on the outside of the ovary, often referred to as a ring of pearls or resembling a black pearl necklace. The inside of the ovary looks dense because that's the part producing excess hormones. The ovary becomes a hormone-making factory, primarily producing estrogen. But when it can't make enough estrogen, the hormone pathway shifts from LH, luteinizing hormone, to testosterone production. This increases testosterone levels, leading to acne, excess hair growth, central weight gain, especially around the belly or abdomen, insulin resistance, which can occur even in lean individuals. So PCOS is not just an ovary problem. It's a brain-ovary communication issue and a hormonal imbalance, factors that can worsen PCOS. Certain things can make PCOS worse. For example, gaining weight. Your fat cells can make a type of estrogen, which causes the brain to send out less FSH. This disrupts the balance further. That's why some people say that losing even a small amount of weight can restore the hormonal axis, and that's true if you're overweight. If you're at a normal weight or underweight, please do not lose weight. That won't help and may make things worse. Diagnosing PCOS, the Rotterdam criteria. To diagnose PCOS, we use something called the Rotterdam criteria. You need 2 out of 3 of the following: polycystic ovaries on ultrasound, high androgen signs either on blood work or clinically, like acne or excess hair, irregular or absent periods. So, if you come to me and say, my periods are irregular and I have acne, you meet the criteria for PCOS. Or if your periods are irregular and you have a lot of follicles on ultrasound, again, that's PCOS. Because the criteria only require 2 out of 3, it's a diverse disease with different presentations. Why blood work isn't always checked. Some people get upset when their doctor doesn't check blood work, but in modern medicine, if the test result won't change management, doctors are trained not to order it. So, if you clinically have irregular periods and acne, we often assume high testosterone and may not test it. That said, you can always advocate for yourself. If blood work is important to you, ask for it. There's nothing wrong with wanting to understand your body better. Common lab findings in PCOS. If blood work is done, we may see elevated androgens, testosterone or DHEAS, increased LH to FSH ratio, especially if tested on day 3 of your cycle, high AMH, anti-Mullerian hormone. This comes from follicles outside the vault, so more follicles equals more AMH. These aren't part of the diagnostic criteria but are often checked to understand the full picture. Additional labs you might need. Because PCOS can affect your whole body, you should also have the following checked. Cholesterol. People with PCOS often have elevated cholesterol. Thyroid function. PCOS increases the risk of thyroid abnormalities, and thyroid issues can also cause irregular periods. Blood sugar. Either fasting glucose, insulin, or hemoglobin A1C, depending on your doctor's approach. We want to know, is your body processing sugar normally? Summary of PCOS symptoms. The hallmark of PCOS is irregular or absent periods. But that doesn't mean if your periods are regular, you don't have PCOS. I think of PCOS like a teeter-totter. At some points in life, you may be controlling it without even knowing. Some patients feel better by eating anti-inflammatory foods, sleeping well, doing moderate or low-impact exercise, following a mostly plant-based diet, avoiding processed foods and refined carbs. Without realizing it, they're managing their hormones, and their periods stay regular. But if they get stressed, gain weight, or eat poorly, their symptoms can reappear. So not everyone with PCOS will always have abnormal periods, but irregular periods are still a key feature to watch for. If you have absent periods, high androgen signs, such as acne or hair growth, you may qualify for a PCOS diagnosis. Think about this. If you've had laser hair removal on your lip, you might still qualify based on prior hair growth. If you've taken Accutane or other acne treatments, that could also count. Additional symptoms can include central weight gain, difficulty losing weight, mood changes, or depressive symptoms. These can all go along with PCOS.
What can you do about it? Let's talk about the big picture.
Number 1. One of the risks of PCOS is that those small follicles can stimulate growth of the endometrial lining. If that lining is never shed with a regular period, you're at risk for endometrial cancer. So worst case scenario, if you never have a period, those small cells keep growing, and that can lead to cancer. This is why having a period is important, even if it doesn't happen naturally. Doctors will often prescribe progesterone, which can induce a period. Let's remember what happens during normal ovulation. You grow an egg, it makes estrogen. Estrogen grows the uterine lining. You ovulate. That egg becomes a corpus luteum, which makes progesterone. If you're not pregnant, progesterone drops. You have a period. By giving someone progesterone, we mimic that luteal phase and trigger a period. Important note, this does not help you get pregnant. Taking Provera or any form of progesterone will give you a period, but it does not mean you ovulated, is not a real luteal phase, is not changing what's happening at the ovary level. It's just helping you shed the lining to protect against endometrial cancer, which is essential. How often should you induce a period? Typically, if you're not having periods or have very long cycles, we recommend inducing a period every 3 months. This is a protective strategy to reduce your cancer risk. What about birth control? Many patients with PCOS are prescribed birth control pills. Some people love it, some don't. But here's what it can do. Protect against endometrial cancer. Prevent pregnancy if that's not your goal. Lower testosterone levels, which is a nice added benefit. Here's how it works. The oral birth control pill increases something called sex hormone binding globulin, SHBG, which is made in the liver. SHBG binds to testosterone, reducing the amount of free, active testosterone in your body. This can help with acne, hair growth, other androgen-related symptoms, other medications. You can also use spironolactone, which is a medication that decreases testosterone production. It's often used for acne treatment, sometimes alongside topical medications prescribed by dermatologists. Important: you can't undo existing hair growth with medication. Birth control may prevent future hair growth, but you'll likely need hair removal treatments like laser or electrolysis to address what's already there. Want to get pregnant? If pregnancy is your goal, focus on optimizing lifestyle. You may still need ovulation induction medications, and that's okay. Even with a perfect lifestyle, some people still need help to ovulate. That's not a failure, it's part of the condition. Top takeaways for improving PCOS symptoms. 1. Drop inflammation. PCOS is highly sensitive to inflammation. Avoid processed foods, refined carbohydrates, limit red meat. Women who ate more red meat were less likely to ovulate. Try 1 serving of meat per day. Use vegetable-based proteins for other meals. Do meatless Mondays. Eat red meat no more than once per week. Exception: special occasions are okay. Have the cake on your birthday. Just don't make sugar and processed food a daily habit. 2. Exercise smart. High-intensity exercise can help with weight loss, but may stress your body if overdone. Moderate, sustained cardio is ideal for weight and hormone regulation. The #1 underused tip? Strength training. More muscle mass, better sugar and hormone processing. Also consider yoga, moderate activity, high intensity and short bursts, if tolerated. Listen to your body. If you feel worse after a workout, that's your body talking. 3. Sleep. Get at least 7.5 to 8 hours per night. Sleep is when your body heals inflammation. 4. Limit toxins. Review your beauty products. Remove plastics and Teflon from your kitchen. Avoid harmful exposures like cigarette smoke and marijuana. If you need help getting pregnant with ovulation induction, that typically means using medications like letrozole or Clomid. I have a whole video that compares the two, but here's the short version. Letrozole, also known as Femara, is associated with a higher live birth rate, so we usually recommend that one as the first-line option. These medications are just pills you take, and they can help restore your period by helping you ovulate. Now, personally, I like to check a few things before jumping into meds. Are your fallopian tubes open? Is the sperm normal? Because if those things aren't working, it can be really frustrating to rely on medication alone. I also like to monitor your cycles with ultrasound. Use a trigger shot to force ovulation and give progesterone afterward. That way I know your body is responding. But some OBGYNs will just give you the pills and say, try to have intercourse, or use ovulation tests, or come in for a day 21 progesterone check. That's not wrong, it's just a different approach. So you'll want to ask, what am I taking? How will I know if it works? What are we testing for? What's the plan if it doesn't work? Are we increasing the dose? How long is this process going to take? The good thing about ultrasound monitoring is that we can use a stair-step protocol. So if you're not responding to one dose, I can immediately move you to the next dose without waiting for another cycle. Now, some people won't respond, even to the maximum dose. In those cases, a few things can help improve response. Metformin, steroids, in some cases, a little bit of weight loss. These can sometimes boost how well your body responds to oral ovulation medications. You can also use FSH injections, but they carry a higher risk of multiples, especially if you have a high egg count. That's why, in some cases, IVF, in vitro fertilization, becomes the safest and most controlled option. Here's the truth. If your periods are not regular, you should see an OBGYN or a fertility doctor right from the start. Find out what's going on. Is it PCOS? Optimize your lifestyle as much as you can. And if you need fertility treatment, make sure you understand your plan. Ask, what are we testing for? What are we doing next? How are we monitoring this? I hope this video helped. I'm going to do a PCOS Q&A, so drop all your questions in the comments. Thanks, friends.